Today we're doing a deep dive into a really critical area of care.
hmm One where the patient's developmental stage just dictates everything.
Exactly. We're talking high-yield pediatric pain management. And this stuff is, it's pretty dense. You need to be so precise.
That's right. So we took all the essential material, the slides, key points, the reasoning concepts, and our mission today is to just distill it all. We want to embed the why behind all the safety rules.
Okay, so how are we organizing this?
We broke it down into 3 logical clusters. First, we'll cover foundational pain principles and assessment, so how we even recognize and measure pain.
Right.
Then we'll get into pharmacologic management and safety. That's all about opioids, dosing, and the big safety priorities. And we'll finish up with non-pharmacologic comfort.
And for each of these, we're going to keep hitting those core pillars, right? The mechanism, the hallmark symptoms, management.
Yep. And the priority nursing actions, and of course, the red flags and those NCLEX traps you have to watch out for.
Perfect. This is all about being that safety net for a kid who can't always speak for themselves. Let's get into the foundations. So our first cluster, pain assessment across the lifespan and its consequences. The big idea here, and maybe the hardest part, is just validating that a child's pain is real.
Exactly. Because historically, pain in children has been so minimized, so under-medicated.
And that has real consequences, physiological.
It has dire consequences. That's the core mechanism. When pain isn't treated, the body just launches this massive stress response.
So we're talking increased heart rate, blood pressure, all that.
All of it. Cortisol levels go up, blood sugar goes up. The whole system is just overloaded.
But the real danger isn't just that stress response, is it?
No, not at all.
It's what it does to their breathing.
That's the key. That is the highest yield concept right here. Respiratory risk. When kids hurt, they instinctively guard. They take these tiny, shallow breaths and they won't cough.
Because it hurts to cough.
Right. And that lack of lung expansion, it leads directly to retained secretions and then
Yeah.
atelectasis,
The collapse of lung tissue.
a total collapse. So you see, inadequate pain control becomes a critical respiratory problem really fast. Their O2 sats start to drop.
Wow, that one insight changes everything. So we're not primarily worried about addiction from, a few days of pain meds.
Yeah.
We're worried about their lungs collapsing from undertreatment.
That's the trap. Addiction is a long-term process. Acute scheduled pain medication prevents a life-threatening complication. So the question becomes, if they can't tell you they hurt, how do you know?
And that's where we get into the hallmarks, especially for infants. What are those signs you just can't miss?
In a neonate, you have to look beyond just the crying. You'll physically see things like sweating, a high heart rate, their O2 sats dropping.
Right.
But behaviorally, watch the face.
Okay.
You'll see that high-pitched, really distressed cry, bulged brows, and what we call the figure 11 expression.
That deep line between the eyebrows.
Exactly, that deep furrow. It's a hallmark of acute pain. And also remember, infants, they can't point to where it hurts. And they are incredibly sensitive to their parents' anxiety.
And as they get older, their understanding of pain gets, more complicated, which can be a trap for us.
It really can. A preschooler, say 3 to 6 years old, they might actually think pain is a punishment.
For being bad.
Yeah. Or they might think their pain is so obvious that everyone must already know. So they might even deny it. Then you get to the school-age kid, and they get it, they understand disease, but they might pretend they're fine to look brave.
And what about adolescents?
The teenager. They don't want to seem weak. They often just assume you, the nurse, know they're in pain, so they won't complain if they feel like they're expected to just tolerate it.
So the priority action, no matter the age, is to validate it.
Always. Validate the pain, regardless of the mask they're wearing.
So when we're picking a tool, like the FACES pain scale, when is a child actually ready for that?
They need 2 things. Decent language skills, obviously, but also the concept of magnitude, understanding more versus less.
And if they don't have that, a toddler, maybe.
Then you default to a behavioral scale. The FLACC scale is the standard: face, legs, activity, cry, consolability.
Okay, here's a reasoning question. A nonverbal 14-month-old. What's the one behavior that screams acute pain?
Generalized body movement, thrashing their arms and legs, active resistance. That is a huge red flag. You have to evaluate for acute pain immediately.
Good to know. And a quick tip about that FACES scale.
Make sure it's one color. It sounds so simple, but if you give kids a scale with different colors, they'll often just pick their favorite color, not the face that matches their pain.
Of course they would. Okay, what about quick management for infants?
For short, sharp things like a heel stick, Sucrose solution is great. A little sugar water on a pacifier. Local lidocaine injections are also totally fine. But here's the absolute hard stop.
What's that?
No ibuprofen for any child under 6 months of age. The risk of bleeding is just way too high.
Got it. Okay, let's do a quick recap of this cluster.
Okay. The core mechanism is that stress response leading to atelectasis. Hallmarks are age-specific, like the figure 11 in babies. Your priority action is to validate pain and use the right tool, FLACC, for nonverbal kids. And the big trap to avoid is worrying more about addiction than the immediate respiratory danger of undertreatment.
All right, let's move on to cluster 2. Opioid analgesia, safety, and monitoring. The big idea here seems to be keeping pain relief steady while being relentless about managing side effects and watching their breathing.
That's it, exactly. And the first rule for continuous pain like after surgery or for a terminal illness is your dosing strategy. It has to be scheduled.
Around the clock.
Around the clock. You're trying to maintain a steady level in the blood so the pain never breaks through. PRN, or as-needed dosing, is only for breakthrough pain, like from moving around.
And if you miss a scheduled dose, you're just playing catch-up.
You're playing catch-up, and the child is going through these awful peaks and troughs of pain and sedation. Scheduling prevents that.
Okay, so once the opioids are on board, what are the side effects we absolutely have to manage proactively?
Constipation, 100%. It's expected, and it must be prevented. Also, itching pruritus and sweating are very common, and obviously respiratory depression.
And what about for an epidural specifically?
With epidural opioids, you really need to watch for urinary retention, nausea, and itching. And just as important, know what's not expected. Diarrhea and hypertension are not opioid side effects.
Good distinction. What about PCA, patient-controlled analgesia? When can a kid handle that?
They generally need to be over 5, and they have to be able to understand the concept, I push this for pain, and be able to physically do it.
And it's a no-go for certain kids.
Absolutely contraindicated if there's any head trauma or significant developmental delay where they just can't understand the cause and effect.
Let's clarify something that often gets confused. Tolerance versus withdrawal.
Right. Tolerance is an expected physiological response. Over time, the body needs more of the drug to get the same pain relief. That's normal in chronic treatment.
And withdrawal.
Withdrawal is what happens when you taper the opioids off too fast. The body reacts, and you see symptoms like nausea, vomiting, abdominal cramps. It's an adverse event we try to avoid.
Okay, let's talk about the absolute #1 priority. If a child is sedated, what is the single most important safety check you can do?
You have to visually and directly assess their respiratory effort.
So you mean actually watching their chest move?
Yes. Watching the chest rise and fall, assessing the quality of their breathing, that action comes before anything else.
Before looking at the pulse ox.
Before the pulse oximeter, before the cardiac monitor. I mean, the technology is a great backup, but your eyes on that child's breathing, that is the priority nursing action, period.
So what if you see a huge drop in their respiratory rate, like a 4-year-old going from 42 down to 16?
That's an emergency. You have to evaluate for respiratory depression immediately. If you think it's an overdose, if there's apnea, you intervene with naloxone. That's the antidote.
And while you're doing that,
you get them on continuous pulse oximetry, and you prepare to calm them down, because when the pain relief is reversed, it can be very, very agitating.
Let's go back to constipation. You said prevention is key. What does that look like?
It's vital. You need to push fluids, encourage high-fiber foods like bran cereal, prune juice, and get them moving if possible. And a simple clinical tip, avoid cheese. It can make it much worse.
Right. And what about for really painful procedures like burn debridement?
You'll often see a combination of fentanyl, which is a very fast-acting opioid, with a sedative like midazolam or Versed. Nitrous oxide is another option for short, painful procedures.
And finally, when is it safe for them to be discharged after sedation?
You need 3 things. Stable vital signs, a patent airway, and they have to be able to sit up on their own without help. Non-negotiable.
Okay, quick recap for the safety cluster.
The mechanism is that balance. Pain relief versus respiratory depression. The hallmarks are those expected side effects like constipation and itching. Your top red flag is a sudden drop in respiratory rate. That means naloxone. Priority action is scheduled dosing and visually assessing breathing first. And the trap is relying on a monitor instead of your own eyes.
All right, our final cluster, complementary therapies and procedural planning. This seems to be about using non-drug methods to tackle not just the pain, but also that anxiety that comes with it.
That's the core idea. These therapies help kids cope. They reduce anxiety, and they can actually make the pain medications work better.
But they don't replace the meds.
Never. They're supportive. They don't make pharmacologic control unnecessary.
So we have to match the right technique to the right kid and situation.
Right.
What works for a baby versus, say, a kid with chronic pain?
For newborns and infants, it's all about tactile comfort. So, sucrose solution for a heel stick, swaddling, gentle massage. For a school-age kid facing a quick procedure, distraction is your best friend.
Like blowing bubbles.
Blowing bubbles, music, guided imagery. But for chronic pain like with juvenile idiopathic arthritis or sickle cell, that's when you bring in the heavier duty complementary therapies like hypnosis or more sustained guided imagery.
That's a great distinction. Let's talk about that anticipatory anxiety you mentioned.
Oh, it's huge.
Mm-hmm.
That's when a kid starts crying the second they walk into the treatment room just because they remember a painful thing that happened there before.
They're afraid the treatment will be worse than the actual problem.
Exactly. That fear is a major barrier. So a huge priority action is to always reassure them, explain what's happening in an age-appropriate way, and even let them see and touch the equipment. Demystify it.
Okay, here's what sounds like a classic NCLEX trap.
Mm-hmm.
Knowing the difference between a true non-pharm intervention and just a topical medication.
It is a common trap. You have to know what has a drug in it. A regional nerve block
Yeah.
or topical creams like EMLA. Those are pharmacologic interventions.
They're not in the same category as swaddling.
Not at all. Swaddling, heat and cold packs, TENS units. Those are non-pharmacologic. You have to match the complexity too. Sucrose is for babies. Hypnosis is for complex, chronic management, not a simple distraction.
What if you're in a hurry? An urgent IV needs to be restarted. What's the go-to?
Distraction. It's fast and easy to implement right away.
But
But if you have the time for a skin puncture like a lumbar puncture, the priority action is to use a topical anesthetic like EMLA or LMX4 beforehand. Numb the skin first.
okay, last thing in this section. The idea of recurrent pain. What's the specific definition there?
Recurrent pain is episodic pain that keeps coming back over a period of 3 months or more.
Like migraines.
Classic migraines or the pain crises you see in sickle cell disease are perfect examples.
Great. Let's do a final quick recap for this cluster.
Okay. The mechanism is reducing pain perception and anxiety. Hallmarks are using distraction for acute procedures and guided imagery for chronic pain. The red flag is misidentifying something like EMLA cream as non-pharmacologic. And the priority action is to use these strategies to boost coping and help your drug therapy work even better.
That was a fast, really high-yield journey. So if we boil this all down, what are the 3 big pillars a nurse needs to take away from this deep dive?
You know, it really does come down to 3 interconnected things. First, accurate, age-appropriate assessment. That means looking past the words or lack of words and reading the developmental cues, the toddler thrashing, the teen acting stoic.
Right.
Second, safety-first pharmacologic intervention. That means scheduled dosing, being obsessive about preventing constipation, and always putting your visual assessment of breathing ahead of any monitor.
And the third?
Complementary enhancement, using those non-drug methods to help the child cope, to reduce their fear, and to make the whole experience less traumatic.
It really reframes the nurse's role. It's not just about giving meds. It's holistic safety management. You're the final safety net.
You are. And to wrap this up, here's a final thought for you. We talked about how historically infants were operated on without any anesthesia because of this belief they didn't feel pain.
Which is just horrifying to think about now.
It is. So the question is, what area of pediatric care today are we maybe still underestimating? Where are we potentially misjudging the child's sensation, their fear, or their cognitive experience? We can't let our routines make us forget that individual kid's experience, especially when we know they're often more scared of the treatment than they are of the pain itself. So how can you always improve your transparency and your advocacy for them, no matter how old they are?